everyone. It's an honor for me to address you today in this very important conference. And I'm going to talk about the emerging role of artificial intelligence in radiology. Now, what is artificial intelligence? It's not a new concept. The term was coined in 1956, and it refers to the ability of computers to learn without being explicitly programmed. It has gained recent popularity because of exponential increase in computing power. Each of us carries a supercomputer of old in our pocket, and new approaches such as deep learning in 2016 have had widespread implications and applications. Basically, AI is the use of high-end computing to find hidden patterns in data, and there is a significant overlap with the field of computational neuroscience. What are the types of artificial intelligence? There is artificial narrow intelligence, and some of you may recognize this picture where Deep Blue, the IBM chess computer, beat Garry Kasparov, the world chess champion. And artificial narrow intelligence is you teach a computer one task and it becomes brilliant at it, like Deep Blue beating Garry Kasparov. Then we have artificial general intelligence. This is an emerging field. It's the next frontier. This is about reinforcement learning. You teach the computer chess and it self learns something else like shogi, which is another game of this kind. So this is where human beings are. And this is what we want AI in healthcare to be at. And then there is the concept of artificial superintelligence. The world is divided about its possibility. This describes the point in time when AI becomes stronger than humans, as we've seen in science fiction movies, when robots will rule the world. I hope this never happens. Now, there are two broad categories of AI applications. One, what humans can do, but AI does better or faster. Humans can monitor CCTV cameras, but maybe 15, 20, 25 at one time. Whereas with using AI, you can monitor thousands and hundreds and thousands of them. Similarly is the example of Google Translate, which can translate any language, whereas human beings may be able to translate one, two, or the brightest amongst us, a few languages. The other application is what AI does, but humans cannot do at all. And this is something Google Maps, which we use on a daily basis. There is no way that I, as an individual, can tell how long it'll take for me to go from point A to point B. But as we know, the Google Maps can do it very, very accurately. Now, AI has percolated into all aspects of healthcare. It's there in preventive and population health. You can predict cardiovascular risk factors from retinal fundus photographs via deep learning. There is next-gen psychiatric assessment, which is happening using smartphone sensors to monitor behavior and mental health. It is, of course, making big inroads into diagnostics, especially in radiology, where it has extensive applications in triaging, pre-reading, quantitative imaging, in improving image quality, so on and so forth. And we'll see that in great detail. In pathology, it's slowly picking up due to lack of digital infrastructure, but digital pathology is the next frontier. In genomics, machine learning techniques form a part and parcel of next-gen sequencing. In therapeutics too, machine learning and other technologies, it is said, are expected to make the hunt for new pharmaceuticals quicker, cheaper, and more effective. Learning or training is the fundamental basis of all AI today. Supervised learning involves feeding labeled data into algorithms so that patterns in data are recognized. This is the traditional technique, and most healthcare AI is focused on this. However, it is labor intensive, and the ground truth being good is very important, is vital. As you hear, garbage in, garbage out. So the ground truth has to be very, very robust and accurate. Higher the accuracy, better the labels, better the outcome. For example, Facebook's face detection only works once pictures of people are tagged by multiple users, and chest X-ray algorithms require thousands of labeled images. We have an example here to simplify what I've been saying. If we look at the letter 3, different people write it in different manners, different ways, and all of these different types have to be fed into the computer for it to be able to recognize it when it is fed in this. Similarly with chest X-rays or CT or MRI. How is an AI algorithm developed? Most important step is to find data and find as much heterogeneous data as possible that addresses the problem you're trying to solve. Say chest X-ray, we should find chest X-ray from the ICU, from the inpatient, from outpatient, from multiple hospitals, multiple vendor machines, X-ray machines, make it as heterogeneous as possible. Then we need to train the model. The data is split into training and validation data sets, and the algorithm finds patterns itself on the training data. After that, we need to validate the model. The trained model is validated on the balanced data, like we had split the data into two halves, half for training, half for validation. Then this data is used to validate the algorithm. And that is what you generally hear when someone says, my AI algorithm is 95% accurate. We heard so many developers make AI algorithms for chest X-ray, for chest CT during the COVID pandemic. And so these were all validated on their own data. However, the proof lies when this model is brought into clinical use, is put in a hospital or in a diagnostic center. Before that, we need to test the model, and the trained model is tested on data from a completely new site, hospital. And that's when the robustness of the algorithm we come to know whether something which is claimed to be 95, 98% accurate may actually turn out to be only 50%. And this is where the challenge lies in bringing AI from the bench really into the clinic. The radiology value chain is as follows, and we'll show how AI is changing radiology practice. We have patient scheduling and preparation. Then there is the actual scanning and image acquisition. There is processing and analysis of this data. And then finally, the holy grail, what the radiologist does, which is the diagnosis, and AI is making inroads into each and every one of these. If we talk about patient scheduling and preparation, this is a paper from Mass General, and it came in 2018, where machine learning for predicting patient wait times and appointment delays. This is an AI algorithm which is quite accurately able to predict based on data that it has as to how long a patient may have to wait. Is the whole waiting list becoming delayed? And based on this, you can ring up a patient and say, Mr. So-and-so, your appointment was at 2 o'clock. Kindly come at 3 because, you know, it's going to be delayed. And it has been seen that this algorithm works quite well, quite robustly. Then is predicting scheduled hospital attendance. Many times we book patients for scans, and some of them will not turn up. Today, I'm booking a scan for a patient for day after, but today, because 4 patients out of the book 25 didn't turn up, I'm sitting free. This AI algorithm is able to predict very accurately the which out of those 25 patients will actually not turn up based on their previous data. Scanning and image acquisition. This is work that we did and presented at the ISMRM meeting, as well as at the European Congress of Radiology, where we were able to reconstruct using an AI algorithm developed by us, diffusion weighted images and T1 weighted images from T2 weighted images of the brain without actually having to scan for T1 or diffusion. This is an example. This is a patient who has a chronic infarct in the left frontal region. This is a true diffusion image, and chronic infarcts do not show up as bright on true diffusion. Same was the case on this virtual diffusion image. This virtual diffusion image was obtained after we fed the AI algorithm this T2 weighted image. This is the same case showing on the T2, we hardly see any abnormality, but diffusion, true diffusion, shows an acute clot infarct in the brain. And the same was very nicely shown even on the virtual diffusion image. These are some more examples which show that this AI algorithm not only picked up the acute infarcts, but was able to differentiate between acute and chronic infarcts, though on the T2 weighted image to a radiologist, they all appear similar. Even a tiny little infarct in the head of caudate nucleus was picked up on virtual diffusion. This is another, even more of a moonshot that we tried, which was that from CT scan of the chest, can we generate PET images? And this again was presented at the Radiology Society of North America meeting in 2018 by our group. And this is, we call it synthetic PET. That's a CT image. This is the true PET, where you can see these areas of increased uptake of FDG. And this is a synthetic PET, where again, you can see very nicely what was shown by a true PET scan. So this is a PET image generated from a CT image without actually having to do a PET scan, without having injected FDG in the patient. This is another example. The input CT image, that's the true PET, and this is synthetic PET. So these examples show that even though this was a moonshot, something like this is possible using artificial intelligence. Where exactly it will lead us in the future, time and more effort is going to tell. Then using AI, there can be automation of the MRI protocoling process. Protocoling means putting the cut lines on the MRI images so that every time that the scan is done, the cut lines are the same. This can be done automatically by using AI algorithms, and several of the vendors have this present in their newer MRI scanners. Then again, reconstruction of 7 Tesla-like images from 3 Tesla. And this is a paper, this is a 3 Tesla image. This is a true 7 Tesla image. And this is a reconstructed 7 Tesla-like image from this 3 Tesla image using an artificial intelligence algorithm. And these two look pretty similar. This is something that is a few startups already have this available. This is a post-processing tool, and this can also maybe a 1.5 Tesla image can appear like a 3 Tesla image, or we can go back to the 0.5 Tesla MRI scanners that we have using AI, they will be cheaper, and we can get similar kind of image quality using AI algorithms, which will be able to reduce the noise and increase the signal uh, uh, with the AI algorithm. Again, this is to show the same a 2-minute image and high resolution 8-minute image, and using AI, you're able to do synthetic ASL 2-minute image, which appears pretty similar to the 8-minute image. So using this, we may be able to cut down dramatically the time of scanning on MR. This was the first FDA cleared CT scanner and this was in 2019, where GE got this with AI built within, where the radiation dose can be reduced, and those noisier images can be made diagnostically very adequate using AI reconstruction algorithms. And more vendors are coming up with this kind of AI-based reconstruction. Coming on to processing and image analysis. And this is a paper we presented along with our collaborators, which was automated lumbar spinal canal stenosis detection, where automatically using an AI algorithm, the measurements are made, the area, the anteroposterior dimension, even the degree of obstruction, of compression, all of those, the labeling, the heights of the vertebral bodies, the intervertebral discs, the extent of disc protrusion, all can be automatically seen using AI, making the task of the radiologist that much easier. There can be automated liver, vessel, and tumor segmentation. So liver volumetry can be done automatically using AI. And also the tumor can be segmented out, its exact volume can be shown, and also its relation with the blood vessels, all using AI. This was also a poster we presented at the European Congress of Radiology in 2019, along with our collaborators. This is our collaborators from KIBIM in Spain, where there is automated segmentation of white matter lesions. This is a case of multiple sclerosis. So automatically the number of lesions, the sizes, all can be determined very easily. The lesion volume can be determined, and also it can do comparison, because these are patients who need sequential scans, making the task of the radiologist much easier. So this is where AI is working as a radiologist assistant, helping improving the quality of the report, as well as reducing the time taken for making the diagnosis. And now to the holy grail, which is diagnosis. And this AI algorithms are acting as triaging tools. And this was a paper we presented at SIM. And this is now commercially available portable digital DR X-ray machine, where the AI algorithm has been fed into the device, and it recognizes patients who have pneumothorax and is able to raise an alarm because it's a critical finding, and the technician can come to know that there is a patient with pneumothorax, so that this scan is read at the earliest, the ICU is alerted. So this is where AI is acting as a triaging tool. Then this is a paper which we have in the Lancet along with our collaborators, Cure.ai out of Mumbai. This was a paper in the Lancet, the first paper on AI to be published in the Lancet. And here, this was on CT scanning to be able to recognize hemorrhage and fractures, to be able to classify the hemorrhage, and also to be able to generate an automatic CT report. and different kinds of hemorrhage can be labeled, and the volumes and all of that can be determined. Fractures can be seen quite robustly and quite well. I showed you triaging leads to case prioritization. The critical case with critical findings rises to the top of the list of cases that we are to actually report. And using this tool, a critical finding will not get missed, number one. Number two, it will not be that the scan is read after several hours or at times even after several days, and the patient suffers as a consequence. What we need is AI-based quality assurance system where AI reads every scan in tandem with radiologists and highlights the mismatches. And this is a paper we presented again at the European Congress of Radiology. A live dashboard monitors AI performance versus radiologists, marking out the mismatches which are in yellow. And this is a tool that has been developed by our own startup called Carpal.ai. Carpal stands for Caring Analytics Platform, and this is in use in our centers. A second radiologist then acts as an arbiter to say who out of the radiologist or AI was correct. Our own Carpal's experience of AI-based QA, which we presented 2019 at RSNA, not at ECR, was that the AI impact was 12 wrong reports were avoided by AI, 708 normal cases were reread, 46 cases labeled as abnormal, 12 cases with truly missed findings were detected, out of which in 4 cases, the findings were significant. In the others, they were actually insignificant. This is automated lung nodule detection and characterization, again presented by us at the European Congress, work done with Predible Health, our collaborators out of Bangalore, where the nodules are automatically detected, their sizes and volumes automatically generated, helping the radiologist not only in identifying, but also in seeing the sizes. And then when a repeat scan is done after a few months, being able to make an automatic comparison. Automated normal versus abnormal chest X-ray classification, and this can really have impact where if you are certain that your AI algorithm works well and you are able to, using it, differentiate normal chest X-rays from abnormal, then the normal X-rays with nearly 100% sensitivity can be sent off without the radiologist actually having ever seen them, whereas the abnormal X-rays are read by the radiologist, thus reducing their time by nearly 50%. Our own experience of automated normal reporting, a data set of 430 comprising 80% abnormal scans, 7 false negatives as per AI were detected, but none was clinically relevant for the algorithm. So algorithmic performance has improved ever since and is almost 100% sensitive now. Stanford University says AI will be the physician's assistant, putting AI for X-ray onto phone, and even the WHO for tuberculosis has recognized 3 AI algorithms can be used to detect AI. Even diagnosis of Alzheimer's disorder using resting state functional MRI can be very robustly able to show which of those patients who have been scanned may have even very early Alzheimer's disorder. There are 3 main components of AI that radiologists need to be aware of: development, validation, and deployment. Access to strong, reliable data is key to development of AI systems. As we've said, millions of scans with software extracted tags or thousands by dedicated subspecialists with image annotation. Proof of ground truth, that also is a conundrum. Is it CT for a chest X-ray or is it histopathology for lung nodules? What is it? Development of AI is leading to tough questions as to who owns the data. Does the patient own the data? Does the healthcare provider own it? Does the government own the data? And what about de-identified data? It seems that de-identified data can be shared, but a lot more will be said in the days and years to come. Strong validation of AI algorithms is critical for their successful use. And towards that end, we published this paper called the Algorithmic Audit. In fact, we gave it the name, and we are working with vendors to validate radiology AI algorithms. And this was a perspective on how to do it. AI algorithms before use need to be tested on real world independent data. We need to know what data was the algorithm developed on. Does it work on data from a different source? Does it work on data from a different country? Does it work on totally unrelated data? This we need to know before actually using it in clinical scenario. Strong validation of algorithms is critical for their successful usage. And we've talked a little about validation, and time does not permit me to go into more details. Thorough validation can be done retrospectively or prospectively. Retrospective analysis, there is no chance of harming patients. There's no liability. It is easy to do at scale. However, it is hard to check clinical implications of a certain tool. Prospective analysis is extremely difficult to do. Chances of harming patients in case of AI biases the results. But the most important fact, as far as establishing the validity of AI is concerned, would be a use of this data. It is important to explain AI algorithms, and this is the first paper on opening the black box of AI, original investigation done by our group, published in Academic Radiology in 2020, where we've attempted to unbox the AI and really tried to get into the mind of the AI tool and try to see what is it that it's actually looking at when it makes a certain diagnosis or makes a certain representation. And this is something I think which may interest some of those who are into this tool. The FDA is currently creating better, simpler frameworks for AI regulation. And this is our paper, which we wrote on concepts in US FDA regulation of artificial intelligence for medical imaging in the American Journal of Radiology. Seamless integration into radiologists' workflow is the final, most critical step for AI. Integration with the currently existing PACS and radiology information system. AI may run on premise or on cloud, depending on patient privacy issues. Individual hospital or diagnostic clinic may have its own way, but AI should be able to run on both. And also, there should be continuous feedback on AI performance so that to the department as well as to the AI developer, so that the developer is able to improve the AI algorithm based on the feedback. In the end, AI, I feel, will not substitute doctors anytime soon. However, AI will be doing some machine-like human functions in the next few years, probably next 2 to 3 years. It'll auto measure everything. It will flag studies with critical findings. It'll identify normal scans, whether chest X-rays, head CT, mammograms, and it'll auto pull relevant data from electronic health record systems. What is the future for young doctors and physicians? AI will work certainly as a radiologist assistant, improving productivity and quality. It will replace radiologists for certain areas of reporting. It will help clinicians read scans and may lead to turf erosion. It will help in reading scans in underdeveloped parts of the world with limited number of radiologists and will really improve the healthcare delivery systems in those regions. It will impact teleradiology providers and possibly lead to improvement in turnaround times, productivity, accuracy, quality, and at the same time lead to lowering of costs. However, questions regarding liability of AI generated reports still remain, and these need to be addressed. But one thing is for sure, it will definitely improve turnaround times and reduce healthcare costs. In conclusion, I would like to say to the healthcare fraternity at large, I would like to quote Jack Welch, the legendary chairman and CEO of GE Healthcare, who said, change before you have to, and also control your own destiny or someone else will. Thank you very much for this opportunity. Bye-bye.